Good afternoon, ladies and gentlemen. This is Dr. James Lyons-Weiler coming to you live from Pittsburgh, Pennsylvania, WWDNYK Studios on the show Unbreaking Science. So, unless you have been, I don't know, under a rock in the middle of the earth or something, the whole world is coronavirus these days, and we are, a lot of discussions going on, a lot of positions going on. I'm obviously very, very upset over how our government and people in the government decided to politicize this issue first and foremost. Second, tried to position themselves financially so that they were the ones that had control over as it goes, the revenue streams over testing, leading to a fiasco. We're going to talk about that, and the question of the origins. So, with all of these questions, the advances in treatment, is this a bioweapon? All these things flying back and forth. I'm a PhD. I've dug deep into the data. I have a new publication we're going to talk about that. But I'm really, really super excited because the person who's going to help me sort this stuff out for you is a person who I respect. He's a family man. He is one of the most ethical, straight shooters I have ever had the pleasure of discussing and getting to know a little bit. I want to welcome Dr. Jim Meehan. Thanks for coming on.
Thank you, Jack, Dr. Jack. That was such a great introduction, and I appreciate it. You honor me.
Right on. So we have a lot to get into today, but let's give people a little bit of background. What kind of medicine do you practice?
Yeah, so I practice preventive medicine, addiction, and hormone restoration. I began my career in ophthalmology. I trained at some of the top institutions in the country: Washington University, Barnes-Jewish Hospital, and St. Louis in ophthalmology. I've been I'm a former medical editor of the medical journal Ocular Inflammation and Immunology. I've got a lot of experience in reading science. I had some experience, Dr. Jack, that really kind of formed and forged me for what it is that I do now, which was as a medical editor, I got two studies showing an association between vaccines and retinal hemorrhages, bleeding in the back of young children's eyes, that a university out of Italy and one from the West Coast were saying, well, there's this really powerful correlation between the timing of the appearance of these retinal hemorrhages and the administration of vaccines. And two independent sources, very good methodology, large numbers, solid science. And so I recommended those for publication in my journal, and they were denied. So I went, the senior said, hey, what's the deal? This flies in the face of everything that we're taught in the practice of ophthalmology, which these retinal hemorrhages, these dot blot hemorrhages in the back of a young child's eye were considered cardinal signs of shaken baby syndrome.
That's right.
Or child abuse. So it was really compelling. It was a compelling story that needed to be examined. Like, that's what we do in science. But for some reason, despite the excellent methodology of this science, they were denied. And I was told by the senior editor, Jim, you don't know how the game is played. And I said, I don't know how the game is played because I don't play games. Explain to me. And it was simply, Merck is a major donor to this university, and if we publish this kind of information, there will be repercussions for you and I. I'll lose my professorship. You'll lose your residency position. And I was flabbergasted. It just happened to be a hill that I didn't want to die on, and it wasn't a time in which I had enough, experience under my belt to understand just how big this problem is. But I've seen it played out since that period of time. But I guess to fully answer your question, I spent the first part of my career as an ophthalmologist, and it was fine. I made a ton of money, 10,000 eye surgeries, did a lot of good, but it just wasn't fulfilling my purpose and my passion. I was really frustrated that we spend so much time medicine in stages of disease. I was paid inordinate amount of money to treat the damage of diabetes in the back of someone's eye. but almost nothing to prevent the disease from occurring. And so that imbalance and that inequity was just really troublesome. So I created a company, the company that I own now, Catalyst MD, and I started designing better systems. I have a medical informatics and computer programming background, so I try to employ better technology to empower patients to take, control of their health and their wellness. I think, and so I, in that process of building a better healthcare system, I retrained in nutrition, functional medicine, preventative medicine. God called me into the treatment of addiction. It's become one of the more, powerful, and it's kind of my ministry. I help lead people out of the darkness of addiction, and then hormone restoration. So I think that one of the most cost-effective approaches to rebuilding health that's been damaged by Krispy Kremes, Mountain Dew, McDonald's, too much glyphosate, too many vaccines, and all of the other problems that our system has foisted upon the population, is to restore the balance of the hormones to youthful levels. And it not only empowers the immune system, it helps prevent you from getting things like the coronavirus, but it helps you to lose weight, gives you a better mood. It gives you, it restores your function. It restores almost every system in the body. And when I went through that, my own experience 17 years ago, where I had a low testosterone, I was lost, I was fat, sick, depressed, inflamed. It was just a dark place. I was inwardly turned. I was less than what I was supposed to be, what I was perfectly made to be. And I wasn't the husband, the father, the man that I was supposed to be. So I went to go get treated, and I got treated with all the wrong drugs, side effects from the Prozac and the Lipitor and all of the Band-Aids that we tend to put on problems in medicine. None of them worked. They all actually made me worse. And I had to figure out the problem myself. And as I figured out the problem, restored my hormonal function, lost 100 pounds, became, free, just clear thinking again, empowered, and seeing hope for the future, I pivoted to be able to provide that for other people, to restore their lives, their relationships, make them better husbands, fathers, and men and women that fulfill the purpose for which they were created. And that's my mission now, and I've never been happier. I love what I'm doing. And there's a series of events that brought me into this, fighting the pseudoscience that's everywhere.
Yeah.
In the world today. And we're going to talk about a lot of that today, I would think, because there's so much of it out there, and we're just being played, Dr. Jack.
Yeah, totally. So, Jim, just in that little overview of yourself, which I thank you for, people can see, the sincerity, the caringness, the humanity that is walking around in this corpus that we call Dr. Jim Meehan. He's, really, there's a few people in the world that I really look up to as much as I do you, and I know how much you love your family and how close you are to them and all the rest. So, what I want to do is, I wonder if you wouldn't mind giving a layup as a medical physician, given all that you've consumed, in your understanding of the pathophysiology of coronavirus. And then I'm going to add a little icing to the cake. So, given what you know off the top of your head, if somebody said, "How does the virus make you sick?" Are there differences to other coronaviruses and things like that? Can you give us a layup on that?
Well, I'll do my best. I've been deep dive into this for the last several weeks. I think, months. We all have we have, to me, we have hybridized, gain of function coronavirus that has pieces of various different, pathogenic, lethal viruses that we've experienced previously. It has components that look like and act like HIV, that it has components of the SARS, 2002, 2003 outbreak, MERS 2012. It's this, strange Frankenstein virus that has these different segments in it and these different insertions. And you know more about this than I do, Dr. Jack, but this virus, however did it, whether it was, slop and spit with pangolins and bats and spilling over to humans or any of the other conjecture I've heard about how this could have evolved naturally, whether it came from a lab, wherever it came from. And I think we'll probably discuss some of those things a little bit later, but whatever it is, we have this, it has some dangerous features. It has some features that make it fairly easily transmissible. The biggest concern is that asymptomatic transmission, that you can actually be one of those asymptomatic carriers, that you can be somebody that may not even show the signs and symptoms of an infection, but you're harboring the virus and leaving little traces on it with every doorknob and hallway that you walk through and breathe into, in a way that someone that is more susceptible you are. There's lots of reasons why lots of people could be asymptomatic. Healthy young people, and this is really, it's not an age thing, it's a health thing. We have a really unhealthy population here in the United States that are very susceptible to the infection of any disease process, influenza, metapneumovirus, all the different coronaviruses. In fact, there's thousands of viruses that kill, tens of thousands of people and hundreds of thousands of people throughout the world every year. And very few of those people are representatives of the healthiest members of our population. The susceptible individuals in our population are susceptible to everything, not just coronavirus. So the first standpoint that we have to understand is, if you have autoimmune disease, if you recently got the flu vaccine, you want to be very careful, because we know from a Department of Defense study of healthy young military personnel that flu vaccination increases susceptibility to all the coronaviruses by 36%, metapneumovirus as well. So we know this about the flu vaccine, by the way, that the flu vaccine will increase the susceptibility to other strains of the flu. It not only will increase your susceptibility to other strains of the flu, it will actually make you more infectious when you get another infection from some other virus. So a community study done, I think it was Minnesota, demonstrated that someone that received the flu vaccine and then became infected with another strain of the flu or an upper respiratory infection would exhale, breathe, cough, sneeze 640% more viral particles with every breath, cough, sneeze. So they were more infectious. I believe that the flu vaccine not only is one of the most unjustifiable vaccines in the recommended schedule, but I think it is capable of creating more disease in our population. And I have a hard time believing that we're the only scientists that understand that. I think that this is where, I lapse into the thoughts of how much of this is just ignorance and how much of this is intent.
Yeah, absolutely. So I've got some troubling analysis that I've done in response to attempts to compare coronavirus case fatality rates to influenza case fatality rates. And if you go back to 2014, the CDC used to separate out influenza from other sources of pneumonia. And so in 2014, It was 55,000 deaths, but there were only 4,500 that were actually from flu. The rest were from coronaviruses and things like that. And so there's a gamish of numbers to work with, and it's really interesting. I wrote an article on LinkedIn that's gone viral on LinkedIn. It's asking the question, are we swapping influenza deaths for coronavirus deaths now? It's going to be interesting how they're going to cook the books, to make it look like they still need a flu vaccine. Because if they only have 4,500, 5,000, 3,000 deaths from influenza. And so one of the things, Jim, that I'm trying to encourage people to do is to pass legislation in their states that every cadaver from every person that's diagnosed with any respiratory virus, that by law, the doctor, the coroner, someone has to actually sample the lungs and the upper respiratory tract and get the ecosystem of viruses that are there and characterize what's present in the person and make an assessment about which virus actually killed this person, so that they can't cook the books anymore and make us afraid of 4,000 deaths from influenza, and there's going to be bad years. There's going to be mild years. And, when they say you should probably go out and get your flu shot, and then they say, well, it's only, 0% effective, or it's only 38% effective, or 18% effective. That's because they're diagnosing influenza. Correct me if I'm wrong. They're diagnosing influenza as influenza disease without necessarily always testing for the virus. It's based on symptoms. It's based on whether or not the person's opinion is, yes, you have the flu, and so they're amplifying the total numbers. But then by virtue of that, the vaccine looks foolishly. So they can't cook. The good news is, Jim, they can't cook.
They're justifying.
They can't cook the flu books and the coronavirus books in the same population. Doesn't work. So we kind of have them right here. And I think if we all push with FOIAs, every state should push for FOIAs right now for their public health departments to report through FOIA the actual number of flu confirmed cases and the actual number of coronavirus cases right now. And if we do that and we get it every month, right, FOIA it every month, and as they roll out the data, we have those data. They won't be able to bury it later. So right now, if you're sitting at home and you're not looking for something to do, look up what a FOIA is. It's a Freedom of Information Act request. Get that information and get it to me somehow. We're going to compile a database of these numbers, and we're going to bust them. But what I'm really interested, Jim, is like, once you get the infection, the virus comes in through your eyes, ears, nose, or mouth, and or through your skin if you have a cut in your skin or whatever. But it looks mostly respiratory to most people. The pathology is that you have infections all the way out through the basal membrane in the alveolar sacs in the lung, and these glassy opacities that the pathologists report are fairly characteristic and diagnostic. It's also double pneumonia. So those are kind of like what's kind of understood about the disease presentation. But not everybody understands. I don't think we really have a good understanding about, for instance, why do diabetics have a 6.3% case fatality rate? And I'm not talking about throughout. You see, let's take a moment here and define case fatality rate. Case fatality rate is what's the probability that you're going to die if you have the infection. So that's a bona fide case fatality rate. You have the infection, as opposed to what number of people in the population, what proportion of people in the population have diabetes and die from coronavirus. That's something different. That's, once you get the infection, you have a 6% probability of dying. I think there's a lot of people that are with diabetes in this country, right? Like 45%. You mentioned it earlier, Twinkies.
Growing all the time.
Mm-hmm. Yeah. So tell us what more you might know about how the disease presents itself. What does it do to the body?
Well, the viruses, all coronaviruses, are these little, spiky balls full of attachment opportunities to, a variety of receptors in the body. There's been a lot of attention paid to the ACE2 receptor as a primary point of contact. There are other points of contact, but that's a real learning. There are various things that we do in the treatment of patients with diabetes. Most every diabetic patient will be on antihypertensive medications that may change their ACE2 receptor density.
Yep.
So we may be actually, there, and I know there's a question out there. There's a lot of things we simply don't know, but we don't know for certain whether ACE2 or ACE inhibitor medications that we use a lot, especially in diabetics, for managing blood pressure and protecting the kidneys, we don't know with certainty whether those are causing a negative effect or a positive effect overall as it relates to coronavirus and infections.
Yeah.
Evidence is the density of ACE2 receptors on pneumocytes, and there are ACE2 receptors throughout the body. The virus can attach. It's not just all about the lungs, right, but it is an aerosolized virus. you're gonna probably breathe it in at some point. And the big issue also that everybody's got to consider, it's viral load. It's how much are you getting in? If you just touch a doorknob that 2 hours before was touched with someone that had a small amount of the virus and it's still there, and then you touch your face or your mucous membranes and it's somehow this a small dose of the virus gets into your body, that's probably going to have a very different outcome than somebody that is a healthcare worker, a nurse, a respiratory therapist that has a poorly fit N95 mask in a isolation room with that is literally full of viral particles, and or a direct contact or whatever it might be. Viral load is important.
Yeah,
the health of the immune system is very important as well. Yes, sir.
Yeah, so at a local university system, I'm not going to mention the name, but I happen to know that for all of this major health university system, there was one point person doing all the testing for all the people that came to the hospital. So if there are 2 or 3 strains of this virus going around, this person in one day could possibly become infected by 2 or 3 strains. And so, yeah, there's the load, and then there's the diversity. Jim, let me share with the viewers here some good news. This IPAC research about pathogenic priming. This is in the Journal of Translational Autoimmunity. It's just been accepted. And pathogenic priming is my term for what I think is really happening with respect to the disease from coronavirus. It's not limited to coronavirus by any means, but there's this idea that once you get this fact that once the animals were injected with the vaccine, when animals were injected with the vaccine in this vaccine safety trials for SARS and for MERS, that then they were exposed to the virus, they ended up being more susceptible to the lung immunopathology. That is, their infection in the lungs was worse. And it turns out that there's many organ systems that are affected by SARS-CoV-2 in COVID-19. And this has been accepted. I just corrected the galley, so it should be out in a couple of days. But what I did was I looked at the homology of the proteins that are all the proteins that are present in the virus, and in looking at that, I found some pretty interesting things. The homology of the virus to human proteins. The first thing is that SARS-CoV-2 immunogenic epitopes. That is the epitopes, the parts of the protein that will induce an immune reaction. Pretty much all of them have similarity to human proteins except for one. And roughly a third of the proteins that have similarity to human proteins are key players to the adaptive immune system. And this list that I've published, they really provide clues on which epitopes or parts of the proteins might be involved in the immunopathology of COVID-19, because I think COVID-19 is a multi-organ, it's a systemic problem, and it's an autoimmune problem where you have this prolonged virus infection. The immune system, it's long. You have a 4 to 5 day asymptomatic period. You have sometimes 38 days until you go to the hospital if you have to, and then after that, you're shedding the virus for another 18 days in your fecal matter. So I'm pointing to the very specific parts of the proteins that might be involved in autoimmunity, priming the individual to future exposures being more deadly. And I make the point, and I think you'll agree, that if they're going to develop a vaccine for this, and we know they're trying to, that they need to exclude these proteins. These are unsafe epitopes that might cause autoimmunity through biomimicry, where you get cross-reactive antibodies in your body because you were exposed to this virus. We already know, like in the UK, they think 50% of the population has been exposed to the virus. Why the hell are these people still being locked down is one question. But what's going to happen next time the virus comes around, or God forbid, if they get vaccinated against it and they experience an autoimmune reaction when their body recognizes the virus and elicits an immune response against 3 or 4 parts of the immune system? This is a disaster, Jim. So we want to talk about immune enhancement as something like because you took your vitamin C. You don't want to talk about immune enhancement because, well, you got vaccinated and you're more likely to die. That's not immune enhancement. That's pathogenic priming. So I wanted to share that with you. What did you think about that?
This is so several things, Jack. Outstanding work. This is so critical for people to understand. This molecular mimicry of the microbial world, a stealth system to evade, our immune system is something that people have to understand. We already have problems with various bacteria. Some of your listeners, I'm sure, are familiar with PANS and PANDAS, pediatric autoimmune neuropsychiatric disorders associated with streptococcus. When microorganisms, when pathogens, adapt, evolve, and escape, a means of escaping our immune system, and that escape is camouflaging their envelopes and their surfaces with the same proteinaceous structures that are seen in the human body, so that the white blood cells that come floating by trying to look for something that is not self and different to identify something that it's going to destroy. But if that virus is coating itself and mimicking the same proteins that we see in the body, then it escapes. This is key knowledge to be advancing in our ability to fight this disease. It's also key to understanding why we have to be very, very careful and cautious, wary of even a vaccine that has always failed. The coronavirus, the reason that we don't have a vaccine for one of the most common pathogens in the world, the coronaviruses, is because of this mechanism. Because when we try to vaccinate and when we tried to create a vaccine for SARS and MERS, and we tested it on animals, it was killing animals.
That's right.
Because of this pathogenic priming. The other key thing that you have done is you have properly branded this phenomenon, because the HOTES and OFIT and the vaccine contingent want to call this process, they want to spin it as what do they call it?
Immune enhancement. Immune enhancement. Yeah.
Make it sound all fuzzy and good. No, this is pathogenic priming. That needs to become the new hashtag. That needs to become the new term, because it properly characterizes the fact that whether it be a vaccine that's administered, that's administering these same kind of proteinaceous antigens and epitopes into the human body, or it's an infection by the disease, your immune system has been turned on to recognize the invading epitopes as well as these the associated molecular mimics. Then you get a secondary infection, or you get a vaccine, or you get another coronavirus that has the same kind of, and same kind of subset of epitopes, and you're gonna have a really difficult time recovering, as your immune system causes so much collateral damage that your tissues are destroyed, are damaged to the point of dysfunction and death.
Well, thank you, Jim. I want to read some of the proteins that people are going to start hearing about on this. Right from the abstract, there's a surprisingly large number of opportunities for expected disturbances in the immune system itself, targeting elements of the MHC class 1 and class 2 antigen presentation, PD-1 signaling, cross-presentation of soluble exogenous antigens, and the ER phagosome pathway. Those are a bunch of big words, but I'll tell you, you talk to an immunologist and you ask them what would happen if you had autoimmunity against 2 or 3 of these things. This is where we definitely have some concern over exactly the mechanisms of what these proteins are doing in the virus. When we look at viral pathology, you might look at it and say, okay, the virus, you have an immune attack against the virus, you get inflammation, and that's going to make you feel a little bit sick. And so for a while, it's like, oh, okay, disease is inflammation. But in the microbial world, if all microbes share proteins against humans that are similar to humans, I should say, to a certain extent, this thing, all of them that will elicit immune response, all of them except for one has a match to a human protein. in a manner that might make that protein a target for your own immune system, and then 11 of them are immune system proteins. Listen, I'm posing a hypothesis here, but I did recast it as pathogenic priming. It's consistent with the original antigenic sin, where, if you get infected one time with something, you're less likely to mount a proper immune response to it again. It doesn't conflate with that, and it's also consistent with this antibody dependent enhancement, which is how they're trying to recast it, because now they know there are antibodies that are involved specifically in the disease enhancement process. It's like they want to come that close to saying autoimmunity, but they dare not. And why wouldn't they
Right.
dare say autoimmunity? Because if this virus can induce autoimmunity, and they're trying to put it in a vaccine, then what? Right? If this
That's
causes
exactly right.
autoimmunity in 7 or 8 proteins, then what? And there's plenty of opportunities here to be concerned, and that's why the conclusion of the paper is hold the phone. You might get away with phase 1 vaccine trials without doing the animal safety studies, but you damn well better do those animal safety studies to see if we have this pathogenic priming. And so, yeah, thanks for chatting with us about it. Do you have
Well,
more thought?
well, Jack, we've skipped the animal studies, and the mRNA vaccine being tested in Washington State right now. They enrolled 45 volunteers. I think they paid them $4,500 each. The animal studies were completely skipped, so we went right to human studies. I have a real problem with that. I'm on the Alliance against human experimentation. I'm on their distinguished advisors board, and I can tell you that we're experimenting on human. Well, we've been experimenting on humans with our vaccine program for a long time, and it's a long experiment that never seems to come to the conclusion that we're causing more harm than the original diseases did in the pre-vaccine era. But what I'm encouraged by is when I saw your science on these epitopes that are present and the potential for this pathogenic priming is. I believe that we've been seeing more of this in vaccinated populations than we realize. I mean, decompensation that you see in people that receive even some of the influenza vaccines or a combination of other vaccines that they might get, you're seeing some symptoms of decompensation, sepsis that is almost unexplainable. It looks like that pathogenic priming in terms of the kind of stuff that we would see with yellow fever and dengue fever and some of the other things that are examples of pathogenic priming.
Sure.
So advancing this, characterizing this, renaming this appropriately and advancing this science is going to help us to be able to, better recognize and focus on what might be going on here, because people are burying that. They're covering it up. They're trying to spin it as, immune enhancement. Brother, it's a dangerous process that we got to be very careful about.
Yeah, I think so. And I'm going to clue my listeners and the viewers in that I agree with Jim, and I suspect specifically that we see pathogenic priming all the time. It just happens faster with COVID-19, so we can see it. It happens in some parts of the population, probably through certainly viral infection that leads to autoimmunity. There's no doubt that we can get Guillain-Barré syndrome. And that would fall under autoimmunity, but it would also fall under pathogenic priming. They're not incompatible. It would fall under any mechanism, any of the mechanisms for autoimmunity, but it adds something new. What it adds is that the first causal factor is the exposure to the viral protein, whether that's through injection or infection. And I'm very concerned, and I was concerned from the beginning, that we might see pathogenic priming in our population and a high mortality in areas that already had SARS outbreaks, that already had MERS outbreaks. Luckily, those were relatively small outbreaks. But now, oh my gosh, if this coronavirus acts this way, and they're talking about a second sweep, and China's dealing with a second sweep through, that means they didn't reach herd immunity. You get a second sweep through this because you didn't have a large enough second surge of this, because you didn't have a large enough population that's immune. And so, of course, I wish that there was a simple way to protect everybody in the population. I wish there was an ineffective way to protect everybody in the population, which is the second thing that I did. This was the first thing I did. The second thing that I did was some modeling that said, I asked the question, what if we did social isolation of 80%, 90%, social distancing, 30%, whatever? What does it do to the spread of this disease? And my modeling and I added in therapeutics. And Jim, at 60% social distancing, which is by any means a moderate social distancing, you take the low hanging fruit, the people that are most susceptible, and you take people that have symptoms, basically. And when a bad cold's throwing through the whole population, you can easily reach 60%. So you socially distance that way, and you add the antivirals, you add the vitamin C, you add selenium, you add the therapeutics that would slow down viremia and stop people from being stop it from being so transmissible. We could end this in 3 weeks. My models say we could end this in 3 weeks, and that we could get back to work if we did it intensely. For just we if they had therapeutics on and say, okay, everybody stay home and use therapeutics at the same time, game over. We get back to work right quick. What do you think?
Yeah, I do think so. I also like to draw a distinction in terms of pathogenic priming between, natural exposure and activation of the complete components of the immune system that occurs when we encounter a pathogen through our mucosa, through more natural means, versus bypassing mucosal introduction, the IgA pathways, Th1, Th2, innate, humoral. When we inject these pathogens directly into the tissues of the human body, we are causing dysregulation of the immune system in ways that I don't think. Well, I know most pediatricians don't have a clue about. I don't think we completely understand, but we're seeing significant evidence of immune dysregulation, a Th2 shift in the immune system that sets us up for overactivation of the immune system, more of this pathogenic priming. So if we're going to encounter the SARS-CoV-2, I think that I would prefer to encounter it naturally. I would like to get a small exposure. I've thought about going around and licking the doorknobs at Walmart or something like that. Get something, just get it over with, because I survived the 1968. My mom and I were pretty sick for a couple of weeks with the Hong Kong flu, the first emergence of H3N2, but we survived it, and many people did. Many people lost their lives, but we survived. The people that are going to lose their lives are going to be the ones that have, for the most part, have made some poor choices in their life. They have they have got their health in such a state of disarray that they are the most susceptible. Now that's not all of them. And I don't want to shame people for being addicted to Mountain Dew, Krispy Kremes, and McDonald's. I was at one point in my life, but we got to understand that we can, as you said, we can do some things to protect ourselves from susceptibility to these viruses, not just coronavirus, not just influenza, but every viruses. People need to understand, and I want to come back briefly to this point that you made earlier about how are we kind of substituting the virus du jour, SARS-CoV-2 deaths for influenza deaths or influenza-like illnesses? You identified something that people need to understand. They've been gaming this death certificate, case fatality rate for respiratory viruses for a long time. All respiratory illnesses are listed and attributed to influenza, so that they can, exactly like has been exposed recently, the coronavirus task forces, they are where they're, Birx and Fauci went up there and said, if they had coronavirus and we just even assume, it doesn't even have to be confirmed, we're going to attribute that death and we're going to count it in the numbers as a COVID-19 death. You could have been an asymptomatic carrier, that got hit by a car, dropped a lung and died, and it's going to count in the COVID-19. You could be that young child that died early. Candace Owens was is on a warpath to release a lot of this kind of information, and you're going to be called a COVID-19 death, whether you were or not. They've been doing this kind of thing with with influenza for a long time,
Yeah.
so they can make those numbers look bigger than what they really should be,
Yeah, let me
so
bring
they
up
can
those numbers, Jim. Let me bring
that
them up. I'll
vaccine.
bring them up right now. So this is an
Yeah,
analysis that I did from the National Vital Statistics Reports, NVSS data, years 2014, 2015. There's 4605 that were attributed to influenza in 2014, and they split out pneumonia. Well, that's pneumonia from other respiratory viruses or other factors, including coronavirus. But yet they combined it when you combine it to influenza and pneumonia, and that's how they reported after 2014. They call it
right.
IMP or they call it influenza disease. You end up with your 55,000, 57,000, 51,000. Now, if you estimate for 2015 and 2016, based on this ratio, it's about 11 to 1 ratio. All causes of pneumonia other than flu plus flu is 11 to 1. Then when you do that calculation, I think it's like 8.1%. You end up with 4,700 cases or 4,200 cases. I think coronavirus is shedding a very bright light on this data, the cooking of the books here. And so that's why we really need to have people in different states passing laws. I think I'm going to advocate here. Let me bring this up. I'm advocating that we pass laws that require that every cadaver get tested for the virus that killed a person with respiratory virus. And if we do that, then they can no longer cook the books. We'll know exactly what's going on with coronavirus. We'll know exactly what's going on with RSV. We'll know exactly what's going on with flu. And they can't cook it anymore to say, oh my God, there's an epidemic. In fact, the definition of an epidemic is that the disease has to cause 7% or more of the deaths in the United States, which is a stupid way to cook the books anyway, right? 7% or more. Okay, so that means that if everybody dies tomorrow from something, right, all of a sudden other things are not an epidemic. Is that who are these people that do these books this way? But I have a question
Yeah.
for you, Jim. You brought up a question that brought up
Well,
diagnostics.
the people
Go
that
ahead.
do that, real quick, let me answer your question. Who are
Yeah,
these people?
yeah.
They're front men and women for the pharmaceutical industry that are working on, laying the groundwork for a vaccine that they're going to get rich from. I mean, Fauci and Birx are front men and women for the Gates Foundation and this world vaccine. It's big money. Anybody that gets this gets a coronavirus vaccine has just got themselves $100+ billion revenue stream. So if that's who's doing it, Jack.
Yeah. Okay. So let's your earlier comment about that you had the Hong Kong flu made me. I wanted to ask you a question. So, Jim, how do you know you're not already immune to coronavirus, COVID-19? How
Right. Yeah.
how do you know?
Yeah. So I don't know. I know that number one, I have a really good immune system. I take vitamin C, I take vitamin A. My vitamin D levels I maintain around 80 nanograms per deciliter, 80 to 90. My body is hardened against viral infection. I haven't had one in a long time. I know how the immune system works and I know how to support it. So, but the thing about coronavirus is, right, it's more than just, this one spike protein. How many, and you might know this, Jack, and I would ask you this because I don't know with specificity, but how many other homologies or similarities in these epitopes exist between SARS-CoV-2 and the more common coronaviruses that are endemic in the population? If you've ever been exposed to some of them, there is some immunity that you have naturally developed. It's strong, it's powerful, it's long duration, and it's probably been boosted year. There's a good chance that a lot of these people that are, getting exposed and asymptomatic have antibodies that have been there for a long time, and they are somewhat protected against SARS-CoV-2.
Yeah, so let me ask you, that's a great answer. Let me ask you a different question then. How do you know that you haven't already been exposed to SARS-CoV-2 and that you have specific immunity to that virus? Because I really don't, I respect you. I want you to keep your station in society. Please don't lick anything in public other than an ice cream cone. Don't go to Walmart. Okay.
Yeah.
just
I was being a little hyperbolic.
Yeah, no, of course you were. But that's a serious question because people know I'm all about antibody testing so that people should be able to have people have the right to know their own immune status before the government, independent of the government, before their boss, independent of their boss. I mean, a pregnant woman can know her pregnancy status by peeing on a stick. Why can't I know my immune status by pricking my finger, putting my drop of blood on a device that I own? I bought it for $10 at CVS, and then I know where I stand. Or why can't I know
You
that? So how do you know
absolutely
that you're
can.
not already immune, that you weren't exposed?
Yeah. Yeah, I don't know that, and I'm looking forward to determining that as this technology is going to become more widely available, because it's inexpensive. We use that same kind of technology, this flow cytometry and ELISA
Lateral flow,
testing
lateral flow
for
assay.
all
Yeah.
kinds. Yeah, lateral flow process. We use this in detecting drugs. We form antibodies to the drugs that people take. I can do a urine drug test and determine 12 different antibodies that exist in that person's body, and that cup cost about $1.25. So we should have this kind of technology available in the next months, certainly within a year, and we need to insist on it. And if it doesn't exist now, then listen, people, it's a huge business model for you. Somebody go out there and do it as we move more of our production back to the United States instead of sending it over to China. This is a business model that somebody needs to get into,
Well, I'll tell
because
you, I've
we
got some
need.
news on that, Jim. So thanks for that
Oh,
swing.
good. I figured you would.
I got
Because
some
we
news
need
for
this.
that.
We need this to defend ourselves against the people that just want to inject our children with and ourselves with
Right.
untested and unsafe vaccines.
Yeah, absolutely. So I'm just going to read because I can't bring this PDF up, but I just this morning I had a meeting with a company, and I don't have any financial interest in this whatsoever. Vibrant COVID-19 antibody assay, the validation study report, analytic and clinical studies, Vibrant America Clinical Lab. They're at Bayport Avenue in San Carlos, California. Vibrant America Clinical Lab. Now, this test uses multiple antibodies, and they have come up with 99% sensitivity, 99% specificity tested on 140 patients. They have 95% reproducibility, over 95% reproducibility. If two different people run the same assay twice, and they have 100% disease specificity. So it's specific to COVID-19 and only COVID-19. Now, I don't have any advice for anybody in terms of finances or stocks or anything like that. And I don't invest in this company myself. I'm on the market for knowledge and information that will bring about reduction of human pain and suffering. And if this test is a laboratory point of care test, and the conversation that I had with them this morning was, you've got to make it so it can be done in home, in private, and they're already working on an in-home test, but they would ship to the population, and then that would be shipped back out. So maybe if I talk with their CEO and things like that, they might change their business model and I'll be working to encourage the FDA to allow testing of asymptomatics privately on this. Not that they necessarily regulate that strongly, but we need to make sure that this is something that everybody can get if they want it, without any centralized reporting. And one of the questions that came up was, well, the CDC, if a medical facility finds a positive test for COVID-19, say with RT-PCR, they have to report it to the CDC. And I said, well, that's fine, but if it's an in-home private test, that's not a medical test. If a woman's pregnant or trying to determine if she's pregnant, she pees on a stick, she doesn't have to report that to anybody, but she goes to the doctor and the doctor says, we're going to run a test. They test you again. So you didn't just make up that you're pregnant. They're not going to start treating you for something without validation. And so you're entitled to your own information. And I think this is the fight that we have to have on this right now, because if people already know and can determine that they're immune to COVID-19, we want to know the percentage of the population that's immune. We want to know if you're individually immune. You want to know if you're individually immune, so that we can know whether it's even worth bothering around with a vaccine. So Jim doesn't know if he's immune. I don't know if I'm immune. Why are we worried about a vaccine if, in another month's time, we all don't need a vaccine because we already had it?
That's exactly right. Well, and I think that's what's caused some desperation in the pharmaceutical industry and the people that are just really blinders on focused on getting a vaccine. You hear Fauci talking about it all the time. I mean, I think Fauci discredited himself significantly when he threw cast doubt and shade on hydroxychloroquine and chloroquine and early when already coming out of it. And here's this guy that is the biggest proponent for vaccines in the history of the world, calling and kind of demanding that randomized clinical trials be performed before we release it on the public. Really? Because you sure don't require the same thing for vaccines.
That's right.
It's just not being done. And you sure want to throw shade on something that's low cost, and is actually showing itself to be a real game changer right now in preventing people from progressing to going on a ventilator, to alleviating the disease and significant numbers of patients. But that's this technology that you're talking about, Jack, this antibody testing is going to be a huge business opportunity. I'm so glad to hear that Vibrant America Clinical Labs is getting into this game, because this technology should be inexpensive. It's going to be high volume. People should be doing it, and they should be getting it from a trusted third-party source. Because I'll tell you something I'm not going to do is I'm not going to be tested by a CDC RT-PCR test. I'm not going to do it. They sent 100,000 plus tests to the UK that were contaminated with coronavirus. They have a sensitivity and specificity that just doesn't make the grade. Some of the original release from the CDC bungled our testing program. They absolutely blew it. If we would have used the same testing procedure that was being used in South Korea, we could have had 1 million tests much sooner than what we did here in the United States.
Yeah, you're absolutely right. So, Jim, I got a question for you.
Yeah.
You saw sensitivity and specificity of the CDC's test. I've been looking for it. Have you seen?
Yeah, I saw reports and journal articles, and it was the journal article was recently retracted, but that report showed a false positive rate of 80%.
Okay, was that a China? Was that a China's? I thought that was a study from China. Was that CDC's test? I thought that was from China. But either way,
it wasn't. It wasn't the. I think you are right. I think that is the China PCR.
Yeah. So anyway, if anybody out there finds any sensitivity, specificity, accuracy measures of the CDC's PCR test, I have been hounding the FDA for this, and they're not providing it. They're not coming forth. There's an emergency use authorization of the CDC's test. The CDC turned down the test from Germany. They wanted to make their own, so they maintained primacy. They're supposed to be the gold standard, but guess what? Slapping the letters CDC on your organization does not make whatever you put out the truth. Okay, it doesn't make your gold standard a gold standard. You still have to do science. And they turned down a test from Germany that had already been validated. The Germans took RT-PCR. They made an RT-PCR test. And then here's what they did, Jim. They actually took human sputum samples that had no disease whatsoever. The people had no symptoms. So you get your false positive rate. Okay, and then they took this matched human sputum samples and they put synthetic mRNA from the virus in there so that they could test whether or not, if the mRNA is there, that it detects it. This is not an antibody test, it's RT-PCR. And then they tested it against a whole panel. I think there was about 26 different other pathogens to determine. This was January 16th. And the World Health Organization is like, yo, CDC, we got to test. CDC's like, no, we have to make our own. So they made their own, and then they shipped it out, and it was flawed. It was flawed because one of their primer probe sets didn't amplify what it was supposed to, or it amplified something in humans. I analyzed those primer probe sets. I sent a notice of concern to CDC, and I said, hey, your primer probes are messed up. They said, and I sent it to the FDA. The FDA wrote back. CDC didn't, but the FDA said thank you. CDC changed their protocol, so now they just use 2 of the primer probe sets. I have no idea what the accuracy of that test is. So like you, right. I will never accept a CDC test. And yet, this is the interesting thing. If you create a new test, CDC has to validate it against the results from their test. What is that going to do? That's like playing
Right.
tennis against somebody that's much worse than you. Can you get any better playing tennis if you're playing against somebody that's worse than you? You can't do it. So CDC
Well,
is
here's the other
culpable
thing,
for
Jack.
everything.
In looking the CDC test, and I've been looking for the exact data too. I think I misquoted the Chinese study, but I think that there is some evidence that. Let me do it this way. I've spent some time in the PCR labs, as I know you have. Um, Five amplification cycle amplification. That's a pretty extraordinary amplification cycle. You can get a lot of misinformation. You can have garbage data if you under amplify or you over amplify a PCR test. I
Yep.
think there's lots of problems with this PCR test. People need to understand that this is, there's a lot of variables in PCR. It's not as simple as it's not as precise, I think, as people understand. Can you shed some light on that? You have a lot more experience in
Yeah,
this area.
absolutely. So it's actually astounding that CDC got this wrong, because in terms of designing primers, you literally all you have to have is the genome sequence. You upload it to a website that will then select, a computer algorithm runs, and it selects the primers that are specific to the target, but also don't cause primer dimers. They don't interact with each other. And then all you have to do, and this is what I think CDC failed to do, you just have to take those primer probes and then blast them against the nucleotide database and see if you're accidentally amplifying something else. And if it's specific to your target, you're good to go. And so it's a high school student could be taught to do this. I'm dumbfounded that the CDC got this one wrong.
Yeah,
I'm
it's
totally
almost like
dumbfounded.
they intentionally designed it wrong. I mean, I can't keep going there. I mean, listen, we know the CDC is full of fraud and corruption. They have their own scientists that are blowing the whistle on the fraud and corruption going on at CDC, and it goes way beyond William Thompson and the MMR study. It goes way beyond the Spider Group. There's so much fraud and corruption at the CDC. I don't trust much of what they're doing, and I know how this web of players is all connected, and how they've designed a test that is not as precise as it could be. It's not as specific as it could be. Their protocols for amplification is too high. They've got a bad test, and it's almost like it was designed to fail, but to fail in a that amplifies the data. That it's more of this misattribution of case fatalities. It's about exaggerating the numbers to pave the way for the vaccine.
But it fits, and so if how in the world would a test get? I don't understand how a test could possibly be contaminated with the virus. That blows my mind, because the
Yeah,
design of the test, you email the information to another lab. There's no reason whatsoever for a virus to be in a PCR test, ever, ever, ever. You literally email it to another lab. How did the virus get through email to the lab that makes the test? So if that's not intentional, I'll eat my hat, and somebody needs to go to
right.
prison for that. That's
I,
crimes against humanity right there, buddy.
It absolutely. I mean, there's the swamp at the CDC has got to be drained. I mean, I would advise Trump to fire them all and start over, because that deep state is just too dangerous. They're making too many mistakes. They cost American lives with the failure in their original test kits and their follow-up replacement that was supposed to. I'm not so sure that it's anything more than another part of the problem that we're experiencing
Yeah,
here.
absolutely. So I have a 5-part series on ending the epidemic. I did one on the CDC's deadly fiasco. I'm all over that. There is one way that the kit, I should correct myself. One way that the kit could be contaminated is if they shipped a positive control. But that positive control would have been completely inactivated, and it doesn't have to be the virus. It just has to be RNA or RNA that is similar to the virus, that contains part of the virus. It doesn't have to be. They're stupid. They're either stupid, incompetent, or they're corrupt. And you take your pick. Either way, they don't belong at the center. And this is an interesting point. by putting all of our eggs in CDC's basket, we have centralized all of the risk for bioweapon attack too. If we're going to get to bioweapon, but I want to talk treatment first. But think about it. We have centralized all the roles, responsibility, the CDC's culture. If there's something uniquely wrong to that culture, whether it's Stanford University, Harvard University, it doesn't matter. If you put it all in one place, you're not going to find the right solution. I'm proposing that we make a heterogeneous network of a biodefense network located at places that nobody knows. The CDC doesn't, hello, here's our address. This is what we're doing. If you do a bioweapons attack, bomb us first, right? That's stupid. Do a heterogeneous distributed network of labs that are responsible for this. They don't answer to the CDC because CDC's corruption. And they're well funded, but they're not funded to the point that they have to make an epidemic every 3 years to keep, or every 2 years to keep their bloated facilities. Their job is one job, one job only, is just to detect bioweapons circulating in the United States and to create and to always be rapid ready with a response about what the hell we're going to do.
Yeah. Well, decentralization is always the key. I mean, we can see in China what centralization does, but we can see here in the United States in our CDC, when you centralize too much power and control and you give, and the other, huge mistake that we're making at the CDC is that we give them the ability to own and license patents to the pharmaceutical industry. And they have done so in over 50 vaccine patents. They are a vaccine company. And those CDC scientists and the organization itself are profiting from the vaccines that they, funding and patenting. Same thing with the NIH. They are able to license those to industry, and so they have a financial incentive and a bias that can, for the same vaccines that they're then, recommending on the universal schedule. I have a real problem with that. We need to decentralize and disconnect those kind of processes. We cannot allow industry to have that much control over our decision making.
No, absolutely. We do not have a viable bioweapons response. We're totally vulnerable. That's something that this has proven to us, which means CDC has abdicated one of their primary responsibilities. They're frozen. They're, like Thompson said, they are absolutely frozen. They can't go in the right direction. They can't go in the long direction. They're just frozen in time. It's like 1986 all over again. So let me ask you, as an MD, we talked about how the virus probably causes disease. I'm curious about your take on treatments, because I'm in touch with a lot of MDs about this. A lot of people are saying that this is a very, very simple, straightforward virus to treat if you know what you're doing. So what have you heard? What do you know? What do you feel comfortable sharing?
Well, we've heard a lot about chloroquine and hydroxychloroquine. I'm going to come to those specific therapeutics, which I think are a little bit farther down the process. And there's been a lot of talk about those, but I teach patients and I share frequently kind of how to prevent viral illnesses in general. We need to understand that, most of the viruses that cause flu-like illnesses that they get lumped into this big number that longer about the severity of flu this year. Most of those viruses are not known. They are not detected. We do not have a antibody or PCR test for every virus that causes human disease. More than 55% of the cases in a large analysis ago, the virus was and the cause of death, the pneumonia, but it was called flu-like illness, right? 14 to 17% of those cases were coronavirus. There's a significant number of metapneumovirus, and about 30 some odd percent only were influenza. So you have to protect yourself against a sea of different viruses. And how do you do that? Well, you don't get vaccinated for every one of those things. No, you focus on the defense system that you were born with. And that gets stronger as time goes on, as long as you give it the resources that it needs. So I start with what I call the three key elements of viral illness prevention or supporting your immune system. And we use those in a preventive fashion. So those are vitamin A, vitamin and D. So in a preventive, to prevent the disease, you're not sick yet. Maybe it's, right now it's floating around, you're isolating, but you don't want to get it. I'm going to dose, at lower doses, regular supplementation to support my immune system. I'm going to do about 3,000 milligrams daily of vitamin C, maybe more. If I take 5,000 just every day, all the time, anyway.
Yeah, that's the
Vitamin D.
FDA's. I want to jump into there because vitamin C is an important one. There's a guy named Keith Baggerly. Everybody needs to look up Keith Baggerly. His mom runs a vitamin C website, but he is an MD PhD who works on cancer, and he actually redid the math that the FDA did on vitamin C recommendations, and he says it's at least 12,000 is where they should be for the typical person, that they made a mistake. When you go out in the afternoon for sunshine, right? You're gonna get. I'm sorry, I'm talking about vitamin D. So vitamin C, 5,000 is right. You say?
Yeah, I mean that's a good number, but no, you're actually right. I think you're probably remembering that most animals. So we don't produce our own vitamin C. We have to get it from our diet. Animals will produce body size equivalent of about 12,000 milligrams per day in their intestines. Mm-hmm. So 12,000 milligrams of vitamin C per day is not an unheard of amount. You would have to that. It will cause some bowel intolerance. And we're going to get to, in fact, let me go through the preventative kind of daily maintenance. And then we're going to talk about the hammer and what you do when you get the signs of it. Cause then we're going to go to higher levels of vitamin C, 25, 50,000 milligrams of vitamin C to knock out that illness in 24 to 48 hours. I'll provide this document to you, so maybe you could link it to the thing, Jack, to the show. Yep. But vitamin D. So I look at, you can dose it on body size. It'll be in the document, but I regularly take 10,000 units, and you can get your vitamin D measured. It's a low cost test. And you want to get your vitamin D certainly greater than 60. I personally try to target my patients and myself to about 80 to 90 nanograms per deciliter of vitamin D in the bloodstream. The best way to get vitamin D is to get sun. So during the summer, get outside, get the sun. Magnesium is really important to hundreds, if not thousands of pathways in the body. So 400 to 800 milligrams. I like magnesium glycinate taken at bedtime. Now, here's the big one that kind of gets into the coronavirus area: zinc. Zinc is really important to the health of our immune system. We're going to find when we talk about hydroxychloroquine that zinc is a role player in that game changer therapeutic. But zinc is really important in these viral diseases. You probably need to be taken as a maintenance dose, 20 to 25 milligrams a day. Glutathione, about 500 micrograms. Liposomal form daily. You can also do, my favorite way to do it is subcutaneous injections of glutathione. You can do for about a $80 per month supply. You can actually get a prescription for injectable glutathione and inject a half cc, 200 milligrams per glutathione, and you can inject that subcutaneously, and that will provide you the master antioxidant, the fire department of your immune system, your body, that is so important into mitigating, toxic damage, inflammatory damage. Glutathione is really, really important. And then selenium can be very important, about 100 micrograms today. My favorite way to get selenium is, I got it in my cabinet right up here behind me, is Brazil nuts. 3 to 4 Brazil nuts is about 100 micrograms of selenium. It's a therapeutic dose. So get you some good, delicious Brazil nuts and take your Brazil nuts like a vitamin every day. So that's the kind of basic, regular, preventive maintenance dosing. But at the first signs of viral illness in the Meehan family and any of my patients, we go to what I call the vitamin ACD hammer. And the ACD hammer is going to literally hammer higher levels of vitamin A, vitamin C, and vitamin D into your body for the next 3 days. You're going to get about 200,000 units of vitamin A. This is adult dosing. In my document, there's pediatric dosing as well. Vitamin C, you begin with an initial loading dose. of about 3,000 to 4,000 milligrams, and then you take 1,000 milligrams per hour, at least 6 times per day for 3 days. And then vitamin D, 10,000 units, 5 times per day for 3 days. You will knock out almost any viral illness. You'll support your immune system in a way. You'll, recirculate and replenish your high vitamin C level. You'll give your immune system what it needs, what is so deficient in so many people suffering these viral illnesses. Most of the people, actually, I would say the overwhelming majority of people that die of a flu or a viral disease and get counted in these flu-like illness numbers, they have vitamin D levels that are below 20, and most of them are below 12, according to the clinical research. We need to really, we have the capability to be testing all these things in people that are suffering serious disease in our hospitals or dying. We should be able to have a database that has all this information so we could determine that here's the risk factor. Why is it that 99.999% of people that die of the flu or some other viral illness have a vitamin D that's less than 12? Well, we might want to just inexpensively treat and prevent disease at the foundational causation instead of just trying to inject expensive vaccines over and over again, not supporting the immune system, but in fact damaging the immune system, when we could have solved the darn problem with vitamin D, low-cost supplements.
Absolutely. So, Jim, thank you. Your camera's a little frozen. I don't know what's going on your side, but what I'd like to do is I'd like to say, if you're an IPAC supporter, you follow IPAC, and you're involved in what we're doing, and you know how to develop a database, get a hold of me, because what I'd like to do is, based on Jim's comments and some research that we've done, we do need an outcomes database for SARS-CoV-2 treatments, for COVID-19 treatments, and who's tracking the outcomes of these kinds of treatments? They're treating it like it's nothing, that is not important. And yet we know, how many doctors now have I spoken to that have said, and we're going to run a series, we're planning a series, and Jim, I hope you join us on it, where we have a roundtable discussion about treatment and we bring this to the fore. If we can create an outcomes database where medical doctors log in, they put in all their information, and then they totally de-identified patients, they just report numbers. I'm not interested in anything other than numbers. You can put in the gender, you can put in, approximate age, and maybe a note or two about their past medical situation. But really, we just want to know what percentage of people have had successful treatments with these kinds of therapies. Thank you for that. I think that's really valuable information. I'd ask everybody to share this video and point to that time point. Now, given that my research is pointing to this as an autoimmune disease, when you have somebody that's undergoing a crisis, I'm trying to communicate to the medical community, you need to start thinking about this like they're having an autoimmune crisis, and think of anaphylaxis. Think about interventions, because there's some anecdotes, there's some case reports, I should call them, that people that have a particular type of lymphoma who got coronavirus disease, when they received their standard treatment for that shut down their immune system, they immediately got better, and the disease resolved like instantaneously. And so, the vitamins are important, but also, we really don't understand the mechanism of action of hydroxychloroquine against viruses. And I also want to go out there and say, I did some research. We talk about Anthony Fauci demanding for the first time in his life that science be done, so far as I know. I've never heard him say we need randomized prospective clinical trials ever. And, it's over this hydroxychloroquine. How many clinical trials do you think there are that FDA considered before they approved hydroxychloroquine for use against malaria? How many large-scale, double-blinded, randomized placebo controls were there? That, right? We know malaria works because the military used it and it worked. And then, there's some reference in Wikipedia that there was a government-sponsored clinical trial with no reference. I can't find a reference. Now, there are some that have subsequently done that, but guess what? Hydroxychloroquine is malaria is becoming resistant to it, but we don't understand its mechanism. So in terms of treatment, the medical community needs to start looking at this as a systemic disease, not just a respiratory disease, which brings us to ventilation, brings us to oxygen, brings us to, if you need to be able to breathe, why are they not throwing these people into hyperbaric oxygen therapy, hyperbarics, to give them all the oxygen their body could ever possibly handle?
Right. Yeah. Well, the other thing that people need to understand is that ventilator management of patients is absolutely a high risk, dangerous, difficult process. That there are so many things that can go wrong. Some of these cases, I've reviewed a few of the cases that looked like they had a heart attack, and the heart attack was being attributed to the virus, but the reality is they dropped pressures below critical points.
Uh-huh.
You could see it in the Swan-Ganz catheter, the CVP lines. I mean, ICU management and ventilator management is tough business. You want the smartest person in the state running that ventilator because it's easy to make mistakes. The way I learned the ventilator years ago, the knowledge has evolved tremendously, and it's very difficult to keep up with. A lot of the cases that have probably passed away on the ventilator to COVID-19 could very easily have been medical mistakes, and I've seen some evidence of that already. The other thing I wanted to address, Dr. Jack, was we might, the great thing about crises like this is we really dig in and we learn a lot.
Yeah.
And we are learning something about chloroquine and hydroxychloroquine. We may have a better understanding about how it actually works. And this is where we come back to the combination with zinc. So hydroxychloroquine and chloroquine seem to open up these channels that allow of zinc to the cell, and that bringing that zinc into the cell is blocking the polymerase and the writing of the viral message, the replication and transcription to create the viral particles is being inhibited by that influx of higher levels of zinc in the body. So we want high levels of zinc. We want the hydroxychloroquine or something that will open up that channel and allow that zinc to flood in and decrease viral replication.
What are your thoughts on selenium?
Yeah, there's some concern about the selenium in this situation, and so I have my concerns. If you think you have a coronavirus infection, I would probably not do the selenium right now. I think there's enough concern. I don't understand the mechanism. Do you?
Sure.
Do you, Jack?
No, at the onset, I was told that selenium. There's studies that show that selenium in cell tissue prevent the entry of SARS, and that also uses the ACE2 receptor. So it's got a similar spike protein. But that brings us to the next topic, and really an important topic that we actually don't see eye to eye at all on. And so this is going to be a lot more interesting, I think, for a lot of people. A lot of what we said, I think a lot of people have heard from other places. But, early on, I became, infamous, I guess, about something that went viral. Del Bigtree had me on a high wire, and I said on the high wire, at this point in time, the evidence that I have in hand tells me that the most likely hypothesis out of 4 hypotheses was that this was a laboratory-created virus. Because I thought I saw a link to something called P shuttle SN. And I promised Dell and I promised everybody I would test that hypothesis. And I went about testing that hypothesis immediately. I spent doing nothing else for about a week and a half, doing phylogenetic analysis of all of the SARS and the SARS-like coronaviruses that were in the published databases. And I was interviewed by Epoch Times a couple of times. I was interviewed by a lot of people. I was on Christian Broadcast News, and my analysis came up with something that was quite different than supporting. In fact, P shuttle SN, is in a completely different part of the phylogenetic tree than these. That's one thing. And, there's an Epic Times video that's hot right now, and it lays out with our beloved Judy Mikovits supporting it, saying that because there's 100% similarity between the spike protein or not the spike protein, but one of the proteins that's in SARS and this virus, that this must be a Frankenvirus, as you laid out earlier. And I've looked at the genome sequences, I've looked at the protein sequences, and I want to discuss that. So I want you to share, if you don't mind, if you share your understanding of how you formulate your opinion on whether you think this is something that might have been created in the lab.
Well, I would say that it leans less heavily on genomic analysis because first of all, the reason it looks like a Frankenvirus is because for this to evolve naturally in spillover from bats, pangolins, and human hosts, there's this sequence of improbabilities that I just can't do the math on to come up with anything other than an infinitesimal probability. I mean, yeah, you can make an argument that these things could occur in nature and spill over to other species, and or you could have been exposed to something at the wet market and it got into your body, and then you kissed your wife who had a different virus, a different version of SARS or MERS or HIV,
Mm-hmm.
and they mated and hybridized. You can make that argument, but that argument relies on a series of improbabilities, or a series of probabilities that in sequence they become improbable. And so that's where I come down on it is, you do have some sequences. So how do you explain that the HIV homologies in the same genomic structure as something that has SARS elements and elements of MERS?
Well, let me take a crack at that. Thank you. So the Indian study that was published was not peer reviewed, and they found 4 segments of protein that were very short protein segments. That out of all of the proteins, out of the thousands of short segments that are found in there, these 4 match the HIV genome. And they didn't have a significant e-value. That's a statistical measure of whether the match is significant or not because they're so short. And the shorter a sequence is, the more likely you're going to get a match by chance. So the improbable becomes probable. Second, the reason why they retracted their own paper is because some other people in bioinformatics, not me, but some other people, found that those same stretches of proteins matched other organisms like plants. So they tested the wrong null hypothesis. The right hypothesis that they should test is what's the probability that any 2 viruses are going to share 4 sequences this short by chance alone? And they didn't test the right hypothesis. They promised to go away and test the right hypothesis and resubmit their paper, but that we haven't heard from them since. So the other thing is how many other viruses out there have those kinds of matches between them by chance alone? So I want to take a moment here and I want to lay out for you what I think is the best evidence that I think that it's not from the lab, and it does involve genomic sequencing. But then I'm going to tell you a scenario that I think you'll find falls within reasonable probability. This research report, which is available on the IPAC website, is entitled Motif Pathogenicity Typing. SARS-CoV-2 coronavirus may contain a unique, likely pathogenic protein motif signature, also found in a natural isolate from 2005. Now, one of the things that I kind of object to in the Epic's Time study, and this is not peer reviewed, I did send it to a major publication to be reviewed, and they reviewed it, and the reviewers came back and said, we don't know anybody who thinks that this was made in the lab, so they didn't accept it, right? They're trying to just make this thing go away. But one of the things I take issue with the Epic Times thing is that they're making the inference that because this thing has a spike protein that's like the SARS spike protein from 2003, that therefore it must have been recombined. It got the spike protein from there. I'm partly responsible for that thinking because I pointed to P shuttle, which had a spike protein that was SARS-like, and it looks like it went there. But if people read my analysis, they'll see that the SARS spike protein in P shuttle is more like the SARS spike protein than it is this spike protein. This is a unique spike protein. It's different. All beta coronaviruses have a spike protein. So to the extent that a chimpanzee has, opposable thumbs, right? Well, they got that from evolution. We got this from our ancestors. We didn't get it by somebody recombining genes into humans to give us opposable thumbs. And so let me show you the actual phylogenetic tree, because there's a really cool story here. In this right here, we have this is my best estimate of what's going on. This cluster down here is the Wuhan market virus at the time. It's actually SARS-CoV-2 now, so there's no implied disparity there. But the Wuhan sequence itself is supposedly closely related to this pangolin sequence. And it's in this cluster, a very interesting cluster, with the Wuhan Institute for Virology with a spike. This is the spike protein sequence itself that the tree is based on. And the Nanjing command, this is what they were talking about so here's the Nanjing command, the Wuhan, and then boom, we're in humans. And the data looks like it's saying that the Nanjing command had a sequence that they gave to Wuhan, and from the Wuhan Institute for Virology, it got into the humans somehow. And here's the spike protein in the P shuttle way up here. Okay, so it's a completely different cluster. And this wouldn't cluster that way if it came from P shuttle. So I ruled out P shuttle. All of the other chimeric sequences that I could get my hands on cluster separately as well. But the real killer here is this pattern over here, which is hard to understand if you're not a domain expert. But look at these. These are what are called structural motif patterns. And this is the N terminus of the spike protein, and this is the C terminus. And the spike protein motifs imply specific structure and potentially function of the protein you're looking at. And this cluster of beta coronaviruses has this particular pattern. Just look at the patterns of 4 elements here, the black, the gray, and so on. And there's 4 of them down here. And you can see that the pattern down here is very, very different. And what this is there's a truncated N terminus S1 protein. That's unique. That's not in P shuttle, so it rules out P shuttle. It's not in any of the other ones. This spike protein it's also missing these 2 elements here, which are called the She3 and the KXDL. Those 2 pieces missing from this entire clade of organisms tell me that, well, it's present in all of these. This may be ancestral because it's present they're absent way up here as well. So this thing is probably an ancient ancestor or relative of the SARS protein. And then it has this really strange GP40-like. And GP40, as you know, in envelope proteins is also found in HIV. Where did that come from? Well, it turns out that particular GP40, nobody else is talking about that GP40 is not similar enough to be recognized as a functioning GP40 unit. It looks like evolution is moving it towards that way. So let me lay out the scenario, if you don't mind, that I think is reasonable. In 2005, the Chinese published a sequence. It was a full genome sequence of a SARS. They called it SARS. They published other sequences from SARS as well. Nobody knew at the time that one of those sequences had a spike protein like this one. The Chinese didn't know it, and our researchers, Ralph Barrick's lab, who works with our military, didn't know it because Ralph Barrick's lab downloaded that sequence and downloaded 3 other sequences. He then calculated what's called a consensus sequence, nucleotide position by nucleotide position, to recreate the virus in the lab. Now, if he was trying to recreate SARS, he wouldn't have included that strange spike protein. So just looking at the protein sequence itself and the nucleotide sequence itself, you can't see the functional motifs. They never would have included that one sequence from 2005 in this analysis if they knew that it was a distinct protein. It would screw up their virus. And the virus that they actually recreated in the lab would have been a hybrid between a SARS-like protein, SARS-like virus, and SARS. They were trying to study SARS at the time. And so I don't think the Chinese knew what they had. I don't think Ralph Barrick knew what they had. Luckily, when you do a consensus, it's 3 out of 4, best 3 out of 4. So they did reconstruct a SARS virus. They didn't reconstruct SARS-CoV-2, If they, my contention is Ralph Baric and his team may well have recreated that SARS-CoV-2 by accident if that's the only virus that they had, and they would have reconstructed it, and we could have had an outbreak way back then. So what I think happened, and that bat sequence that sequence came from, was isolated from the anus of a bat in Hong Kong. That sample, that guano sample, was then studied, and it was published. What I think happened was Wuhan Institute for Virology and Nanjing were studying this thing to develop a defense, like a vaccine, to develop something. It matches so perfectly that the structural motif pattern matches so perfectly. And then somebody like a janitor or a cage cleaner got into this, and they got infected, because that's how it happened like 9 times with SARS in China. There were 9 escapes of SARS that were controlled because it didn't spread as bad. So they have some sloppy laboratory things. Now, if I'm the military, if I'm the Chinese military, Jim, and that phylogenetic tree makes it look like this virus, we were working on it and we gave it to Wuhan, holy crap, am I going to cover it up? So, their actions of covering up, which Epoch Times made a big deal about, is also consistent with, oh my God, this makes us look guilty as hell. There's going to be a war. They're going to think we did this. We have to cover this up. So the military went to Wuhan Institute, took it over, destroyed the samples, and said, just make this go away. Because they're not scientists. They don't know what else to do. So they came in with a sledgehammer and destroyed it. Now, what I think happened was, I don't see evidence of a hypothesis that's necessary for recombination, because this virus, I believe, or a virus like it, was found back in 2005. That's a long time ago. And in terms of probabilities, I'm glad you stated it exactly that way, Jim, because every time that the virus, a coronavirus like this, infects one person and another one like it gets into the body, it always recombines. It's just the biology of how the transcripts are made. You get the S1 protein, you get the full S protein, and then the virus is made from those components. So you get this recombination automatically. It's automatically built into the biology of the virus. And so I do think, like, somebody, a cage cleaner or somebody got infected, and then they went home with their wife, and then they swapped spit or something, and she had a SARS. And so, right, I don't see a lot of elements from other viruses in here. I don't think MERS is involved. I can rule that out based on the sequence analysis itself. But I think it's reasonable to think that it's a natural virus that recombined in humans, as much as it is that it might have recombined in the lab in a human tissue culture, or it may have recombined in a mouse in the lab. And I don't know what other people think about it, but I don't think it's a very effective bioweapon because it's so simple to treat. Right, like we've just talked about. So, given that, what do you think, man?
Well, yeah, no, I think that's a reasonable and plausible, explanation for how it could evolve. I mean, let's remember, Mendel didn't have PCR technology and P shuttle to create hybrid. You could have a lab that was had a whole bunch of bats and a whole bunch of pangolins and a few dissidents of the Communist Party that were the means of spillover and recombination and what would look like a natural recombination. I think that narrative implies that we have to assume that we're all using the same tools. We have the same, P shuttle sequences, that we're using the same sequences. And I just think a really high level, and China has some of the best virologists in the world. Yep. That there's all kinds of stories that we could create. But here's, like I said at the beginning, is I lean a little bit less on the genetics and the presence tied back directly to, Nanjing and WIV, because, you could also imagine that if you don't want to implicate yourself, or you want it to look like it's too obvious that it came from you, or you want it to look like somebody else was trying to frame you, you do the same damn thing, right?
Well, that's really interesting that you brought that up, because what the Chinese did as part of this cover-up is they actually redid a phylogenetic analysis, and they made the assumption that the Nanjing sequence was the outgroup. And by making, if people don't know anything about the phylogenetics, I'm sorry. Sometimes I speak Greek, and people, okay. But when you do phylogenetics, it would be like saying, I'm going to do phylogenetics. I'm going to assume a monkey or a squirrel monkey is the ancestor to primates. Okay, fine, that's good. But if you assume that humans were the ancestor of all primates, that's going to flip your tree inside out, like an inside out umbrella, right? So it's the way I talk about it, Jim, is I say, well, what if you're doing a pedigree of your family and then you assumed that your cousin was your great grandfather? What would that do to all the relationships? And so the
Right.
Chinese military,
Absolutely.
with a gun to the head of somebody who knew how to run a computer and write a program and write a paper, said, "Make this go away, or you're dead." And so, how could you make this go away? The guy's like, "I'll just assume that it's the only way I can do it. I'll make it the out group, and by making it the out group, then your cousin becomes your great grandfather, and your sister's your aunt, and it just messes everything up. It doesn't work out."
Right.
And it's so obvious to me as a domain expert in phylogenetics that they were actually doing that wrong, that the person doing the phylogenetic analysis is like, I'm sure that he said, yeah, I'll do it, but it's not going to fool anybody. Somebody like James Lyons-Weiler is going to come along and see this and go, you idiot, that you can't make that assumption. You can't take
Right.
something that's modern and say that it's an ancestor. And so they totally screwed up with their analysis. So there's no doubt that there's a cover up. I think it was laboratory escaped. I don't see any positive evidence, given all of what I know about all the other artificial viruses, that it is laboratory derived. And that's a big distinction. Does it mean that I'm ruling out other technologies that the Chinese and only the Chinese have? No, I can't rule that out. But then Dr. Shi actually learned everything she learned from the American virologist, and so there's something really funny going on in virology between the United States and China.
Here's
But
here's a clue that I think the guy can really, just when it came to me, I was like, this is concerning. Now, you said something. You said it's so easy to treat. Well, when you design a bioweapon, you also design a countermeasure. There has to be something that you can do to protect your army, your people, your country. And so the fact that we've discovered how to treat this in certain populations is not necessarily, discount or discredit the idea that it's a bioweapon. I think we're just really, there's a lot of smart people all over the world that, join forces, share data. It's one of the most inspiring things ever. We now have preprint publication servers where we're
right.
seeing science in a more rapid phase, a more open source way, instead of having, like I experienced, good science thrown away because it didn't fit the narrative.
Yep.
So here's what you see when you go to the Johns Hopkins website that maps all of the outbreaks, and you look at Beijing, which has 20 million people, 20 million residents stacked on top of each other, densely populated. Same thing in Shanghai. Those two Chinese cities, near the epicenter of this outbreak, had less than 600 cases and less than eight in Shanghai and 7 in Beijing, or it's the other way around, but less than 15 combined together deaths. So how do you explain SARS-CoV-2, very transmissible, problematic, asymptomatic transmission, long incubation period, relative proximity to those cities, with an outbreak right at the largest human migration in the world at that time, and they got away with so few exposures and deaths. Now I understand, and I don't even think the tyrannical lockdown of China can explain that low penetrance, that low number of cases and fake case fatalities. I don't think you can explain it without that. They had the countermeasure. The countermeasure was applied to that population, their industrial centers, their leadership, the centers of their government were protected. So I need to find a reasonable explanation that helps me to understand how they avoided with, such minimal impact. I think we discovered the countermeasures. I think that, the hydroxychloroquine, maybe it's ivermectin, zinc, vitamin C. There's probably some Chinese traditional medicine involved in this ultimate formula for countermeasure. I don't know what it might be. They had just started a max vaccination program some time before, so maybe they for some countermeasure at that time. I
Well,
don't
yeah,
know, but
no,
yeah,
okay, so I'll agree 100%. So one of the things that we just talked about for a long time was how CDC is fudging our data.
yeah,
China definitely fudged some data about coronavirus, most likely due to the fact that the world was looking at them saying, "What the hell are you doing over there? You got to get this thing under control." And when it came to Beijing, the numbers from Wuhan were much worse. And then the Chinese came out and said, "Well, wait a minute. There's an S type and an L type, and that explains why it was slower outside." I don't know if I believe that or not. We need some experiments to know that. But no, you're exactly right. There's a disparity between the number of cases reported for Beijing and what they should have been for Wuhan. But let's factor in the fact that they clamped down, and let's also factor in, now get this, what I said earlier. If we do hard-nosed 60% lockdown in the United States right now, my models predict if you add therapeutics onto that we can be done in 3 weeks with this, with minimal cases. And that, you're exactly right about the Chinese therapeutic medicine, the traditional Chinese medicine. I think the Chinese are laughing at us about how stupid we are that we're going to all this extent of what we're doing. And they're just,
right.
rubbing their hands together going, economically, this is a big payoff for us. What a bunch of dumb people live over there in the United States because they're committing economic suicide, and all we have to do is let them continue to fight with each other about this, and we'll cash in later. So then there's the very real. Please, people, don't take me as naive. I've read the same things you've read about the hardliners in the Chinese Communist Party who said that it would be wonderful to have a weapon like this to exterminate the United States of America so that they can have the space. Let's not be naive and think that they're not people that would think to do those bad things. But looking at everything that I've looked at, I've been tracking this since January. I am deeply concerned that our reaction is not just an overreaction, but that our very culture of how we handle things with a capitalist society, like I said at the beginning, we're going to stop and pause and make sure that the right people make the money. That costs us a huge amount. Centralization cost us a huge amount of the risk. And I'm going to hold CDC accountable for all of the economic damage. Other people are too. There's a whole bunch of people I never thought would be talking disparagingly about the CDC who are finally waking up to the scale of the risk of this model of doing biomedicine and public health. We need to gut the CDC and just fire them all, go home, you're on furlough, go self-isolate for a while and think about what you did. And then we need to reconstruct a heterogeneous network that's a top secret network. Nobody knows about it. It may already exist for all I know, but I doubt it because we'd have a better response. That constantly thinks about how to react. It's incredible that we have to relearn what we knew with SARS. The CDC actually boasts that the reason why SARS was shut down as well as it was because they had accurate testing and contact tracing. So what happened? Did they
Yeah.
forget how to make PCR? There's something very, very wrong with CDC. Jim, I'm going to give you a few minutes to close out your thoughts, and then we'll say goodbye.
Yeah, one thing I want to say, and is that goes against the idea that they're not just reporting their numbers correctly, is the idea that they're already rebounding and producing everything, all the medical supplies and ventilators that the rest of the world needs. So if they were kind of underreporting significantly, and instead of what we would have predicted, maybe 500,000 deaths in Beijing, they only had 8. I don't think they would be bouncing back as quickly as they are. To me, again, I think they're to provide countermeasures. But anyway, this has been a great conversation. I've learned so much from listening to your ideas, and I've been so interested in learning those. I really appreciated the fact that you came out early with your analysis. I think it was a solid analysis. You worked with the information that you had, and I respect people that do that. That was brave, and it gave everybody an opportunity to learn and for you to learn, and that's what we're doing. And I'm inspired by the process. These preprint publication servers that are available now. Anybody can find them. It's biorxiv.org and medrxiv.org. Now we have this system of delivering early science. It's peer reviewed, which may mean that it's an opportunity to not have science, censored and disappear
Right.
before we get a chance to review it. So
Yeah.
I'm inspired.
Absolutely.
I'm also inspired. Oh, sorry, Jack.
No, go ahead.
I'm also inspired by what the American people voluntarily done. I'm inspired that we love each other enough that done what we had to protect each other. That's an act in my book, and that's what I'll aspire to, is to love each other enough that we'll sacrifice going to the moon, the restaurants, we'll spend time together as family. That's loving your neighbor, and that's what I believe in. And we did it voluntarily, Jack, and that's so important because I know that I will not, in the state that I live in, will not slide, silently into tyranny.
No way.
There have been enough instances of tyrannical lockdowns and government overreach that are completely unnecessary. The American people have demonstrated that it is unnecessary, that you do not have to force us to submit our children or ourselves to forced vaccinations. We're developing technology that will be able to prove that we have antibodies and natural immunity, which is so much better than this crappy disease-causing, immune system dysregulating vaccine program that's never been tested experimentally and proven safe. And yet we lie about it all the time. This crisis, like so many crises, is in a personal life, but it works the same in a country. Sometimes the best people will be forged, and countries will be united and forged for a greater purpose when they have to face challenges and tribulations. We've been generations of complacency. We didn't have to do what the greatest generation did. Maybe we're doing a little picture of it right now, and I think that makes us better, and I'm inspired by that. I'm hopeful for the future because great things are happening.
Yeah, thank you very much, Jim. Listen, I'm going to pull up your website here. That was inspirational. Your website is meehanmd.com, at www.meehanmd.com. There's a lot of information here, folks. Truth Seeker, Vaccine Paradox. This man's been at it for a while. And, he's also got a great, fantastic Facebook page, and he puts a lot of information, a lot of information out there, important information. So visit meehanmd.com and find Jim on Facebook. Jim, you're an absolute gentlemanly, scholarly, medical doctor. You're a rare breed, my man, and it's people like you that should be in positions of making policy advice and decisions. And I hope somebody clues in pretty quick that integrity and honesty in science and in medicine is what's going to allow us to survive this. It's not going to be the profiteering. And, I just want to thank you so much for being part of this.
Thank you for letting me be with you. I enjoy you very much, and I appreciate you very much as well. God bless.
Thank you. Thank you. So listen, folks, if you want some more information, I'll send out a text message of the links that Jim's going to send me. But to sign up for this, you should use your phone and text IPAK, IPAK, to 474747. That's IPAK to 474747. And when Jim has some information about what we talked about today, and I'll send you the links to the articles I talked about, you do that and you'll get those updates. Thank you so much. Signing out, Dr. James Lyons-Weiler from Pittsburgh, Pennsylvania on Unbreaking Science, WWDNYK. Thanks so much, everybody.